Hello, good afternoon. Thank you for the introduction, and I promise that this is just an accent and not a speech impediment. So today I'd like to present the results of a binational survey that we conducted to try to define what the constituents and the expectations of contemporary fluid bolus therapy are. Fluid bolus therapy is a ubiquitous intervention in the intensive care, and information on what clinicians believe constitutes fluid bolus therapy is surprisingly absent. The physiological changes expected in response to fluid bolus therapy by the clinicians prescribing it are also poorly described in the literature. So we carried out a survey aiming to try to develop an understanding of the working definition of fluid bolus therapy as intensivists themselves understand it. We also aim to explore what they actually expected to happen as a consequence of the delivery of fluid bolus therapy in different situations. And so we obtained prospective ethics approval from both the Austin Hospital and from Monash University, as this forms part of my PhD. And we created a deliberately simple electronic survey of stated practice using SurveyMonkey, which I'm sure many of you will be familiar with. We piloted this originally at the Austin Hospital, which is a tertiary referral Metropolitan University hospital. And we aimed to capture respondent characteristics, the constitutions in the intensivist's opinion of what a fluid bolus actually is, and then what they expected to happen from fluid bolus therapy. Participation was voluntary and anonymous, and we approached people through the ANZICS clinical trials group mailing list. So members of each of the clinical trials group centres was approached and asked to distribute emails to their consultant body to participate. We allocated a 2-week period for recruitment, and we sent several reminders during this period to encourage participation. Responses were downloaded into a Microsoft Excel spreadsheet, and we calculated simple proportions and percentages for reasons that I'll go into later. So what did we find? Well, we carried out the study between the 16th and the 30th of June of this year, and 71 units were asked to participate. Because of the mechanism of survey dissemination, we were unable to calculate a response rate because we didn't have an accurate denominator. We did receive 198 responses, however, with 177 coming from intensive care specialists. This was our target demographic, and so we excluded from analysis the 21 responses from trainee doctors. 26 responses came from New Zealand, and this is approximately proportional to the ratio of populations of the two countries. And so, looking at responses by location, as expected, we got more responses from the larger states, with 45 responses from New South Wales and only 4 from the Northern Territory. Almost 90% of our respondents had fellowship of the college or equivalent, with a variety of other qualifications. And 55% of respondents had been practicing for 10 years or less, with 15% practicing for more than 20 years. When we asked questions about fluid bolus therapy, we asked respondents to define what fluids they thought were suitable to use, what would be the minimum volume that they would feel constitutes fluid bolus therapy for each fluid, and what would be the maximum duration of administration for each fluid over which you could still categorise the delivery of that fluid as a fluid bolus. So, what types of fluids were suitable for use as fluid bolus therapy? The 3 crystalloid solutions that we asked about, CSL, Plasmolite and normal saline, more than 85% of respondents felt that all 3 were suitable for use for this purpose. 95% of people thought that 4% albumin was suitable to use as fluid bolus therapy, but only a third of people thought that 20% albumin was suitable to use as a fluid bolus. 25% of people felt that gelatin was suitable, and 4.2% of people felt that 6% hydroxyethyl starch was a suitable fluid for use as fluid bolus therapy. Regarding the volume of fluid that people thought constituted fluid bolus therapy, the majority of respondents felt that 250 mils was the minimum acceptable volume, except as regards 20% albumin, where a minimum of 100 mils was felt to represent a bolus. And as regards the speed of delivery, more than 80% of respondents would deliver fluid bolus therapy over less than half an hour. Respondents were asked to quantify an acceptable physiological response to fluid bolus therapy. In these circumstances, they had to imagine that the fluid bolus had already been given and to describe what they felt, in general, would be the likeliest physiological response. More than 30% of respondents, when a fluid bolus was given for hypotension, would constitute an increase of more than 10 millimeters of mercury as a response. 70% of people would accept an increase of less than 10 millimeters of mercury, but still count this as a response to fluid bolus therapy. There was no general consensus on what a urinary output response would be to fluid bolus therapy, with almost exactly 50% of people believing that an increase in urine output of more than 15 mils per hour was a response, but almost exactly 50% of people believing that a urine output of less than 15 mils per hour constituted a response. When fluid boluses were given for a low central venous pressure, people believed that 30% of people felt that an increase in CVP of more than 4 millimeters of mercury constituted a response. And when given for tachycardia, 60% of respondents felt that a decrease in heart rate of at least 10 beats per minute was required to constitute an adequate response to fluid therapy. If given for a low central venous oxygen saturation, 2/3 of respondents felt that an increase in central venous oxygen saturation of more than 4% was required. And when given in a situation of hyperlactatemia, half of respondents felt that a decrease of more than 1 millimole per litre in lactate was required to indicate a satisfactory response. And so we found that the prototypical fluid bolus in Australia and New Zealand is at least 250 mils of CSL or 4% albumin given in less than 30 minutes. We found that self-reported fluid bolus therapy practice across the two countries varies wildly as regards the type and the volume of fluid and the rate of administration that participants deemed acceptable. There is significant variation in the threshold of physiological changes which are deemed to indicate a response to fluid bolus therapy. This was the first study to document practice in this fashion. This was the first survey to document the expectations of fluid bolus therapy from a physiological standpoint, and this was also reasonably representative on a proportional level across both countries. It was a survey of stated practice and has all the limitations of a survey and a survey of stated practice. And the response rate was uncalculable, and so we have an uncertain denominator. Fluid bolus therapy is a chaotic intervention, and it's one which intensive care specialists have uncertain expectations of. Expanding the survey to other countries and to other specialties appears justified, and we've actually, some of you might have filled out, we've done a nursing equivalent through the ACCCN, and there's actually an international survey ongoing. But we believe that prospective studies are required to document the actual physiological response to appropriately defined fluid bolus therapy are required, and the need is urgent and necessary. Any questions? Thank you.